Okay, good afternoon, good morning, everybody. Welcome to the inaugural talk of this year's University of Toronto Transfusion Rounds. I just want to remind everybody that this video is a video conferenced event. It will be recorded, archived, and excerpts may be used for educational purposes. So by participating, you indicate your consent to recording, archiving, and use for educational purposes. My name is Dr. Aditi Khandelwala. I'm an adult hematologist and a transfusion specialist. I work as a medical officer at Canadian Blood Services, and it is a real privilege that I get to be the chair this year of the University of Toronto Transfusion Rounds and bring some amazing speakers to you all throughout the year. We have an exciting agenda, and our first talk today is going to be by Dr. Justyna Bartoszko. Dr. Bartoszko happens to be on call today, so she has generously pre-recorded her talk and will be joining us for the question and answer period. I'll also have on the Q&A panel Dr. Callum with us as well, so when we have questions, we can discuss them further. To give you a bit of background, Dr. Bartoszko is an assistant professor and academic anesthesiologist at Toronto General Hospital, University Health Network, and at the University of Toronto. Her area of focus is cardiovascular and transplant anesthesia, including blood management and treatment of coagulopathies. So without further ado, I am going to have the pre-recorded session started now. Please feel free to share your questions and answers at the end and hope for a rich discussion.
So hi, and thank you very much for having me at these rounds. I'm just going to go ahead and pull up my screen. So let me introduce myself. My name is Justyna Bartoszko. I'm an anesthesiologist at Toronto General with a research interest in perioperative transfusion. Today I'm going to be giving this talk on albumin use. Of course, I tend to use it in the perioperative setting, but there's a lot of different situations where it's popular, although it's been much more de-emphasized in most general medical populations. And although we actually tend to use it quite liberally in the perioperative setting, there's not a lot of evidence for that. And I'm going to be going over some of the indications as well as the supporting evidence for them. So today my objectives are to review the rules of endogenous albumin, compare it with exogenous albumin, so the blood product or the drug that we transfuse to patients, outline what kind of albumin products are available in Canada, and then go over some of the rationale for their use, including the higher quality evidence for the various indications for which we might use albumin. We'll finish with a quick clinical case just to illustrate some points. So let's get started. So what is albumin? Albumin is, of course, a plasma protein. It's found in the intravascular as well as the interstitial space. It's made in the liver and catabolized or degraded in different areas of the body with a half-life of about 18 days. Albumin, globulins, and fibrinogen are the major plasma proteins. Total serum protein is about 70 grams per liter, with normal albumin levels about 40 grams per liter. So colloid osmotic or oncotic pressure is maintained by these plasma proteins. Oncotic pressure is that part of the osmotic pressure, which is contributed by large molecules. The oncotic pressure is highly influenced by albumin, which accounts for about 1/2 of the total plasma protein content, and along with the other plasma proteins is necessary to maintain intravascular volume. What does albumin do? One of the main functions of albumin, highly relevant to its popularity as a resuscitation product, is its ability to provide plasma oncotic pressure. Interestingly, by weight, albumin is actually primarily an extravascular protein and can be found in the interstitial space. But because the interstitial space is much larger than the intravascular space, the concentration of albumin interstitially is much lower, so the oncotic effect isn't that strong. But that's not all albumin does. It's a carrier of many endogenous and exogenous ligands, including things like drugs. And it can, of course, directly affect their metabolism and whether or not they're available for clearance. And albumin has antioxidant and other properties as well. How is albumin measured? So usually you take a whole blood sample in a green top tube. The tube or the sample is centrifuged, and then the plasma is used to actually measure the albumin level using a specific assay where you get binding of a fluorescent ligand to albumin, and then you get a colored complex with a certain absorbance that's measured. So the degree of the absorbance is directly proportional to the albumin concentration in the sample. There are some limitations with this measurement, so the levels are posture dependent. It shouldn't be drawn if a patient or anybody really is laying flat because they'll probably be falsely low levels because you get plasma volume redistribution. So patients should be seated when the sample is taken. And what do these levels reflect? So now that we've measured the serum albumin in somebody, what does that value tell us? There's lots of disease states that can lead to low serum albumin levels, including even just general malnutrition. On the right is an image of a child with nephrotic syndrome. Low albumin levels reflect low liver synthetic function, nutritional status, cutaneous losses through things such as burns, and then renal disease, for example, nephrotic syndrome, where you can lose albumin. There's only select circumstances, though, where exogenous albumin administration has actually been shown to improve outcomes in hypoalbuminic patients. So just because a patient has low albumin levels does not really necessarily mean that they need albumin replacement. There's only some circumstances where patients are known to benefit. So we've talked about endogenous albumin, what it might reflect and how it's measured. And now let's talk about exogenous albumin. So albumin as a blood product or as a drug product, which is given or prescribed by us to patients. In Canada, our choices for intravascular fluid resuscitation are generally limited to crystalloids, so clear electrolyte solutions, things like Ringer's lactate or Plasma-Lyte, or we can give blood products. Albumin is a blood product. Synthetic colloids, so things like hydroxyethyl starches and gelatins, are not popular here for multiple different reasons. So really, if you don't want to use crystalloids for whatever reason, and the patient does not have an indication for a transfusion, a lot of clinicians will think about albumin. It's one of the few other colloid resuscitation fluids that we have available. It's important to remember, though, it is still a blood product. It's purified from donated human plasma. And most of our albumin actually is imported into Canada because we don't have a plasma fractionation company. In countries like the US, where we import plasma from, a fair amount of plasma donation is from paid donors. So just to give you a little bit of the context around this, it's a blood product. You need to think about where it's coming from when you're giving it to patients as well. In fact, the plasma donation industry was even mentioned in this Time cover article from 2018. Where they were talking about income inequality and economic hardship in the United States. So there's a lot, I would say, related to the context around albumin use that we have to be mindful of, where I really would encourage everybody not to prescribe it indiscriminately for many different reasons. So let's go on to talk about albumin as a drug in terms of how it's available in Canada. So we'll talk about formulations, dosing, and then alternatives to albumin. So there's two concentrations available in Canada. There's 25% and 5% albumin. 25% is available as a 100 ml bottle, and 5% is available in 250 or 500 ml bottles. 25% albumin is used for oncotic deficits. It's a hyper-oncotic solution. And 5% albumin is iso-oncotic to plasma generally, and is used for restoring volume deficits and plasmapheresis. Albumin has been around for a very long time, from the 1940s onwards, and it's been widely used in clinical medicine since then. There's lots of different products available in Canada with slightly different names. Usually when we write an order for it, we'll simply ask for 5% or 25% albumin with the volume that we would like to give in either 100 ml increments for 25% albumin or 250 to 500 ml increments for 5% albumin. There is a difference, though, between 5 and 25% albumin, so they're not interchangeable products. Because 25% albumin is hyperoncotic, it draws fluid from other compartments close to it. So if it stays intravascularly, 100 mils of 25% albumin actually increases your intravascular volume by 450 mils. So it's very similar actually to giving 500 mils of 5% albumin. It's just that 25% can maybe be used potentially for fluid shifts. If you look at the evidence, this isn't always borne out, but we'll talk about that later. So don't be fooled when you're giving small volumes of 25% albumin to patients, for example, especially those that are prone to heart failure or circulatory overload. You can very much precipitate heart failure with even small quantities of 25% albumin. So this is just to emphasize that point. And let's talk a little bit about what the alternatives to albumin are. So we already mentioned crystalloids. I mentioned briefly synthetic colloids, and then of course there's blood products. So crystalloids are much, much cheaper than albumin. A single dose of crystalloid is about $2 compared to $62 for albumin. Crystalloids have to be chosen carefully as a resuscitation fluid too, though. So for example, normal saline is actually a very non-physiologic resuscitation fluid. It's known to be associated with hyperchloremic metabolic acidosis. It's associated with worse outcomes and acute kidney injury. Most of the time, we tend to favor in the operating rooms at TGH plasma light, which is a little bit more of a physiologic resuscitation fluid. Ringer's lactate is okay too. Synthetic colloids, so the hydroxyethyl starches or the gelatins are not very commonly used in Canada. With the hydroxyethyl starches in particular, there's very serious safety concerns. They've been associated with AKI, an increased risk of renal replacement therapy and mortality, especially in critically ill patients. So definitely not optimal. In terms of other blood products, obviously you need a reason to give them. So plasma and packed cells are technically both colloids, but you really should be giving them with a specific transfusion indication in mind, not for volume resuscitation, of course. So albumin has actually become very popular in the OR setting, or historically was very popular, as well as in the ICU, because fluid balance and fluid resuscitation in critically ill patients is tricky and can be very important for their outcomes. So in terms of fluid overload, there is interstitial fluid overload and then a central circulation overload with high venous pressures. And of course, the two are strongly related, but they manifest very differently in terms of their physical effects. So colloids like albumin, they're popular because they're thought to lead to better and sustained intravascular fluid expansion without contributing as much to total body fluid balance or fluid overload. So depending on the disease state, if you're giving a lot of fluid, much of it may end up extravascularly, so outside of the intravascular space. And this can be a significant issue. So for example, if people have edema, this can be associated with skin and soft tissue infection, pressure injuries, longer mechanical ventilation, increased hospital and ICU length of stay. And then central venous pressure being elevated is also associated with its own host of adverse outcomes as well. So that's something that we need to keep in mind. So there's a balance between both of these things. And it seems that for every study demonstrating that albumin is better at effective intravascular volume expansion compared to crystalloid, there's an equal number of studies showing the opposite, or that it has no effect. So it's important to take all of the evidence in balance. And again, we'll touch on it in a second. This is a historical study that I think explains some of the rationale about why albumin is popular amongst some clinicians, and historically was so. The lead author on this is Murphy, and it's from 2009. It's a retrospective study of septic patients with acute lung injury. The main message from these figures is that patients who were more fluid positive in general did not do as well. So a higher fluid balance appears to have contributed to mortality. And there's multiple such studies where this outcome has been repeated. So where we see albumin being used for resuscitation, especially in hospitalized patients or in the critically ill, it's really this kind of initial data that was driving its use. in many different patient populations. And then there's other effects that albumin might have besides just volume as well. So these images are from a review article by Cesar Alocoa et al. In the Annals of Intensive Care. And we talked a lot about how albumin is a major determinant of plasma colloid osmotic pressure. However, albumin also transports different molecules, including sphingosine 1-phosphate, for example, which has protective endothelial effects, acts as a free radical scavenger, and has immunomodulatory and anti-inflammatory effects. So this is related to glycocalyx health, the glycocalyx being that thin, very physiologically and biologically important layer on the inside of blood vessels, which is really thought to mediate some of the adverse outcomes seen in critically ill patients with large volume fluid overload and interstitial edema. And although albumin has a net negative charge, its amphoteric nature promotes tight binding to the glycocalyx, and it actually promotes or is thought to promote glycocalyx function and health, and preserves the vascular integrity, normal capillary permeability, all very important things in critically ill patients where many of these are lost. And then expanding on this theme, this is from a review published by Bernardini et al. In Liver Transplantation in 2019. It describes the pathophysiological background of decompensated cirrhosis. I already mentioned we tend to use albumin a fair bit in our cirrhotic patients, and there's some high quality randomized controlled trials supporting this, but this is kind of the underlying rationale for why maybe it's beneficial in this group. So the systemic spread of bacteria may be due to abnormal translocation from the gut, which activates immune cells. You get production of pro-inflammatory cytokines and markers, along with all of these other substances. And there's a big cascade of events that ends up contributing to circulatory dysfunction and eventually multi-organ dysfunction and organ failure. So in this kind of pathophysiological framework, according to these authors, besides promoting plasma volume expansion, albumin could simultaneously act on several different abnormalities to help modulate immune responses, to work as an antioxidant, to expand intravascular plasma volume, to prevent endothelial damage and activation, to protect all of these extrahepatic organs. So this is kind of the pro argument in the debate of why albumin is so highly studied in end-stage liver disease patients in particular. And obviously there's a con argument as well. This is a slide provided courtesy of Dr. Jeannie Callum. So this just goes over some of the albumin usage by different hospital sites across Canada. So I just happen to work at Toronto General. So the site that here is number one. And this relates in part to our patient population because we are a high volume liver transplant center. We have a lot of complex cardiac cases, et cetera. But, you know, not all of the reasons for why we might use albumin are necessarily based on evidence. So for example, cardiac surgical patients, not much evidence there. So certainly there's a lot of regional variability in clinical practice, and this probably just speaks to the generally poor quality of evidence supporting albumin use out there. So basically what I just said, usually not very good evidence supporting clinical practice. These are the indications. I'll speak to the adult population because that's the one that I clinically deal with. Pediatrics is, they have their own separate indications that I won't get into right now. And so this is based on the ORBCON guidance, but it's similar to the indications listed by CBS. And I've kind of tried to simplify things here. So at the top in green are 3 indications for patients with a liver disease. In the middle are 2 indications for ICU patients that are sort of historical indications, not supported really by evidence. And then at the bottom, we have 3 blue indications that are very specific patient populations. So let's talk about the liver patients first, starting with the 3 indications at the top. So in conjunction with other appropriate therapies like terlipressin and antibiotics, albumin may be part of a treatment strategy that reduces renal impairment and mortality in patients with decompensated cirrhosis. And that's the gist of it. Let's move on to typical ICU patients in purple. So for patients with acute lung injury or severe ARDS, the use of albumin with diuresis for a more negative fluid balance was shown in a couple of studies to improve oxygenation and hemodynamics, but to my knowledge, not really outcomes overall. So overall, it's not recommended for this purpose. For patients requiring volume resuscitation for hypovolemia, albumin should not really be used routinely, but there may be a possible benefit depending on the patient, maybe in the context of sepsis, refractory to crystalloid resuscitation, or perhaps there was maybe a small signal for decreased mortality that's based on the SAFE study, which we will get into in a bit. And of course, there's the 3 special populations in blue there. So ovarian hyperstimulation syndrome as a treatment, not to prevent it. Plasma exchange, which is not a field I have much experience in, and then burn patients who are felt to be unresponsive to crystalloid with more than 50% total body surface area burns. But there's not much of an effect on outcomes from this practice, so it's not strongly recommended and should not be considered routine. These are the indications recognized by CBS. So essentially 25% albumin only in patients with decompensation from end-stage liver disease, and then 5% albumin for plasma exchange or high body surface area burns unresponsive to crystalloid. And importantly, as per CBS, there's no evidence to support albumin in cardiac surgical patients, general resuscitation for low intravascular volume, definitely not in brain injury patients, in patients that just generally have low albumin levels. And CBS also does not support albumin use for hypotension during dialysis therapy. So why is this such a big deal? Excuse me, I'm getting a bit of a dry throat. So given albumin's historic popularity and ubiquitousness, it was actually a big news when a meta-analysis several decades ago demonstrated harm with albumin use. And this really galvanized the medical community into looking more closely at this issue. And this is from an editorial written in 2004. Where Deborah Cook, who's a really big Canadian ICU leader, states questions about the merits and demerits of colloids as opposed to crystalloids in the resuscitation of seriously ill patients have smoldered for decades, sparked by this meta-analysis, suggesting that albumin was associated with increased mortality. And individually and in the aggregate, interpretation of these findings has been challenging. So at this time period, this sparked a number of large, high-quality research endeavors to try and clarify this. And there's 3 large randomized controlled trials in ICU patients that I want to mention to you. So the first is the 2004 SAFE study. So this is almost 7,000 Australian ICU patients undergoing fluid resuscitation. And they were randomized to 4% albumin or normal saline for fluid resuscitation during the subsequent 28 days, with a primary outcome of death from any cause. And there was no difference in the primary outcome. There was also no difference in their secondary outcomes, so days in hospital, days of mechanical ventilation, days of renal replacement therapy, etc. Next, we'll move on to the 2013 Crystal trial. So this was almost 3,000 patients across almost 60 international ICUs. It was a mixed patient population, trauma, sepsis, and other forms of shock. And here the intervention wasn't just albumin. It was actually a randomization to colloid or crystalloid, where the colloids could be gelatins, synthetic starches, etc., or albumin, 4% or 20%. So the intervention was from randomization to discharge from the ICU with, again, a primary outcome of death in 28 days, and there was no difference. In terms of their secondary outcome for days not receiving renal replacement therapy, no difference. They did see some difference in secondary outcomes. So the 90-day mortality seemed to favor the colloid group, which is interesting because subsequently hydroxyethyl starches have been very strongly linked to mortality in critically ill patients. And they were included in the intervention colloid arm here as well. And then there was some potential benefit for secondary outcomes in terms of liberation from mechanical ventilation or weaning of vasopressors, which seemed to follow the same trend favoring the colloid group. It was a pretty small absolute mean difference, may or may not be clinically significant. And then there is the 2014 Albio study, almost 2,000 patients with severe sepsis in 100 different ICUs, randomized to 20% albumin plus crystalloid or crystalloid alone. No difference in 28-day mortality. Again, secondary outcomes at 90 days. No major difference seen here in terms of organ dysfunction, death at 90 days. But during the first 7 days, maybe the patients in the albumin group had a higher MAP and a lower net fluid balance. Again, did not seem to influence mortality. So, since the publication of all of these trials, we've had multiple updates to the Surviving Sepsis campaign. So those very important guidelines. It's important to mention this because these guidelines actually recommend crystalloids as the first choice resuscitation fluid based on the total weight of this evidence. There's only a weak recommendation for albumin use in patients who have only received very large volumes of crystalloids and appear to no longer be responding. So there's really a de-emphasizing of albumin use with some weak support as well, encouraging better assessment of whether patients are actually fluid responsive before you continue with ongoing fluid resuscitation. Now let's pivot a little bit and move to the newest evidence, which we discussed the rationale a little bit before, but it's in decompensated liver disease. So this is the one of the major newer studies looking at albumin infusions in patients with decompensated cirrhosis. Patients with decompensation right now, as we went over in the listed indications, can be given albumin. However, these study authors were wondering about the benefits of routine infusion, not for these known indications. Preclinical studies seem to support the routine use of albumin for this anti-inflammatory role and all of those other reasons. And there's literature suggesting that an albumin level less than 30 grams per liter in cirrhotic patients is predictive of immune dysfunction, maybe adverse outcomes. So the main question related to this study was in hospitalized patients with decompensated cirrhosis, does targeting an albumin level of more than 30 with repeated daily infusions of 20% albumin reduce the incidence of a composite outcome of infection, kidney dysfunction, and death? And I'd like to thank Dr. Yulia Lin, who provided this slide. So this is a summary of the entire albumin to prevent infection and chronic liver failure randomized control trial. The patient population was mostly composed of alcohol-related liver disease, with 777 patients hospitalized with decompensated cirrhosis, randomized to either daily 20% albumin for up to 14 days or discharge versus standard of care. If you were in the standard of care group, you still got albumin for those recognized indications that we discussed. The primary endpoint was this composite of new infection, kidney dysfunction, defined as at least a 50% increase in the serum creatinine or death 3 to 15 days after study initiation, with the earlier deaths not counted as they are unlikely to be related to the intervention. And you can see that there was no important difference between the two study arms, and it certainly didn't reach statistical significance. So again, just looking at the incidence of all of the components of the composite outcome, and really no important differences emerge, even though the albumin group clearly did end up getting much more albumin than the standard care group. So the overall conclusion from this study is that albumin should not be routinely used for decompensated cirrhosis to target a certain albumin level. Importantly, there were more safety adverse events, including pulmonary edema and GI bleeding in the albumin groups, especially since GI bleeding in this population is known to be related to portal and venous pressures. Now I'll talk about one more trial, which is the long-term albumin administration in decompensated cirrhosis, or the ANSWER trial. This is an open label randomized trial. So there were 440 patients. And this is a slide, again, provided courtesy of Dr. Jeannie Callum. The ANSWER trial stands for Albumin for the Treatment of Ascites in Patients with Hepatic Cirrhosis study. So 440 patients with decompensated cirrhosis and ascites requiring diuresis, so spironolactone and furosemide, randomized to regular albumin supplementation or no major intervention. So patients would get 40 grams 2 times weekly of albumin, then weekly for 18 months, or nothing. So there was actually an observed mortality benefit in the albumin group with a 38% reduction in the hazard of mortality over 18 months. So this suggests that albumin may be a disease-modifying treatment in this very specific context. So we've gone over this evidence. How much albumin do we use now? You know, you already saw that slide where it looks like albumin usage is not really decreasing. The slide that I showed you previously with Toronto General at the top, even though there's specific situations where albumin can be potentially beneficial, these are well-defined groups of patients, and we probably are still generally overusing albumin. CBS does provide albumin for clinicians to use at their discretion, even if it's not for an officially recognized CBS indication. And overall albumin use over the last decade, there's, for example, I have data from 2011 to 2014, which Jeannie Callum was kind enough to share, showing across major tertiary care hospitals in Ontario, there was a large increase in albumin use, and this was due to a greater proportion of patients being transfused albumin while the dose per patient remained stable. And this has really important practical implications because albumin, again, is a blood product. We discussed where it came from. We've discussed that it's imported into Canada. There are infectious as well as other potential risks related to its administration as a blood product. And of course, it's very expensive. So it's $62 per dose compared to $2 for Crystalloid. That's not an unsubstantial burden for the healthcare system. So albumin use costs CBS about $21 million every year in Canada. So certainly we can ask ourselves, are there better ways that we could be using these scarce resources? And this is just an interesting case that I want to discuss with you. It's always interesting to chat about the weight of the evidence on a population level, combining, thousands of patients into randomized trials. But there's also individual interesting cases too. This was published by Dr. Warkentin and McMaster. He's a hematologist who's probably best known for characterizing HIT, so heparin-induced thrombocytopenia as an entity. And the message of this slide is that you have to be careful in patients with a propensity to both clot and bleed. So in this graph, you have days on the x-axis here, and then serum lactate over here. And you have your serum albumin level as well as anticoagulant plasma proteins, so antithrombin, protein S, and protein C, with their measurements being shown for the various days. So in this graph, we have the trajectory of one particular ICU patient who was being resuscitated with 5% albumin. So these little gray arrows are every time the patient got 500 mils of 5% albumin. And the serum albumin increase, but it was thought to maybe lead to a general dilution in the anticoagulant factors in this patient's plasma, so including the antithrombin protein C and protein S. And the patient somewhere around this time developed the onset of acral ischemic limb injury, which made the patient quite ill as well, with a rise in the lactate subsequently. And the patient was given plasma, which contains some of these anticoagulant factors, and then you maybe had a clinical improvement now that the patient was not as hemodiluted. So it's an interesting situation where you really have to think about fluid management and the tenuous balance of all of these factors in critically ill patients. So in conclusion, albumin has a long history of use in Canada and globally as well. It's a blood product, it comes from human plasma, and although it's generally safe, there are risks related to transfusion. And of course, there are health system costs as well. Albumin use should always be carried out with a specific indication in mind. As much as possible, we're trying to change the culture within our department of anesthesia here at TGH as well. They're really trying to bring a bit more awareness to this issue and helping to avoid indiscriminate use in our perioperative patients. And that probably applies outside to other patient populations as well. There's no major evidence of benefit for albumin over alternatives in the vast majority of patient populations. And of course, it's much more costly than other alternatives. So thank you very much. And please feel free to email me if you have any questions.
Pre-recorded talk there, Dr. Bertosco, and thank you for joining us. While people put in their questions into the chat that is now enabled, I just wanted to do a couple of housekeeping announcements. First of all, I want to thank everybody for joining us back after the summer, and I hope everybody's doing well. I want to thank our sponsors. They include Orcon, Alexion, CSL Behring, Grifols, Octapharma, Ortho-Clinical Diagnostics, Immucor, Takeda, and Instrumentation Laboratory. And I would now welcome everybody to make sure they also help us get feedback through our evaluation survey. The QR code will be posted in a moment. So we have some comments coming in, Dr. Bertosco. So I'm going to read the first one from Dr. Turti at TGH. I know you showed us a slide for use across Canada, and TGH accounted for the highest use in that table. And Dr. Turti reports that 32% of the 5% albumin bottles are being used on label as best practice at TGH, according to the latest audit that is ongoing. And in the latest quarter, of the 7,000 bottles that were dispensed, about 1,000 of those bottles went to the OR and CBICU. And this is about 15% of TGH's use. And she says that they are scrutinizing it carefully and it's improving. So that's always good to know. The first question comes in from Era. She is a resident, and she says that I've often been advised, usually on medicine or cardiology wards, to use albumin followed by a Lasix chaser in an attempt to diurese fluid overloaded patients with low serum albumin levels. Is there any evidence supporting this practice?
So my assumption here would be that we're talking about, for example, 100 cc's of 25% albumin, thereby followed by a Lasix chaser. So giving hyperoncotic fluid to try, hyperoncotic albumin to try and shift fluid intravascularly to then try and diurese what are probably very volume overloaded patients, for example, with heart failure, I assume, if they're admitted to cardiology, et cetera. So to my knowledge, there's no robust evidence supporting a benefit for hard outcomes, things like mortality or morbidity for this kind of practice. There's, I believe, a number of retrospective studies that may be demonstrating things like more of a decrease in total weight or total fluid balance. But at least to my knowledge, I don't think that there's a significant dramatic difference on outcomes. That being said, this is a very common practice. We certainly do it in our CVICU, in the general ICU setting. Obviously other people have encountered this as well. So I'd be interested to also hear the thoughts of some of our blood bank and transfusion specialists.
I'm happy to hear from my colleagues as well. I will mention that there has never been an RCT for Lasix to reduce chances of having transfusion-associated circulatory overload. That is actually something that we have been trying to do. We've completed a pilot trial with the Quest research group here in Toronto. And what the strategy that has been used by our pilot trial has been to give furosemide pre-transfusion rather than post, to try and decant the patient a little bit to make some room for the fluid that's coming in an attempt to decrease circulatory overload. This clinical practice is quite widely adopted across the country now. So there may be very little time left to be able to do an RCT in this field. So just adding to the evidence piece that you've already discussed, Dr. Bertosco, but I welcome any more comments from anybody else on the line on this matter as well. All right, not hearing any, I'm going to move on to the next one, and hopefully if anybody wants to chime in, they can. So Dr. Callum says the SAFE study showed harm in terms of more RBC transfusions. Do you think this is dilution, or do you think albumin increases bleeding tendencies?
So my personal feeling on this is it's likely related to dilution. We often see this in real time in the operating room with our liver transplant patients, where as they're draining the ascites, some of the albumin that we thought might be useful for intravascular volume support is given, and then you just have a profound drop in the hemoglobin. So you can certainly see this in real time. You know, there is some evidence suggesting some impact of albumin on the coagulation system, but I would be surprised if it was, you know, clinically so dramatic that it actually led to more transfusion and non-severely hemorrhaging patients.
Thank you. Now I have a question from Dr. Cherdy-Gazdovich. Do you think there are other therapies available or future state that would more significantly defend an unhealthy endothelium, S1P imbalances, for those who have real attachment to albumin for all of the physiologic and biologic features in the scientific models?
So as a non-basic scientist, I don't know if I'm the best person to comment on this. I think perioperatively, a lot of anesthesiologists are interested in the mediation of the inflammatory cascade towards patient outcomes. Obviously, we have a huge transplant patient population and a lot of high-risk cardiac patients who end up being very vasoplegic post-operatively and have quite lengthy ICU stays. So I think this is something that people are probably thinking about in detail, more mechanistically. Also thinking about supplementation with antioxidants throughout the perioperative period. To my knowledge, there hasn't been a lot of benefit in existing studies in the perioperative period. But specifically speaking about glycocalyx integrity, I don't know if I have a great answer.
Thank you, Dr. Bertosco. The next is a comment and question from Dr. Catherine Dubé. She thanks you for a great talk, and she's wondering if recommendations will change regarding dialysis patients because of a recent RCT that was published this year, 2021, in Critical Care by Macedo and colleagues that shows less hypotension during dialysis and better fluid removal in patients with hypoalbuminemia, although not mortality. It's so the authors think it's worth pursuing. What do you think about that?
I think those are really interesting results, and I think it's also it speaks a little bit to the question about whether or not there are specific patient populations that stand to benefit. So even amongst all dialysis patients, maybe there's a specific segment of hypoalbuminemic patients for which this practice could potentially hold a benefit for. I think it's a really interesting question, and certainly if anybody does an RCT specifically targeting that population in terms of clinically important patient-centered outcomes, I would be very interested in the results. In anesthesia, we have a lot of studies, usually with small sample sizes, but still under the umbrella of RCT, showing all kinds of soft benefits to albumin use. And then there's some that show, detriments and soft patient outcomes with albumin use. It's really hard to interpret the weight of the evidence in its entirety, but certainly looking at these very well-defined patient populations is really interesting. And thank you for pointing out that reference.
So the exciting thing in this field is that a definitive dialysis trial has been funded in Canada. Thank you, Dr. Callum, for pointing this out, which is being led by Dr. Ted Clark to advance our knowledge. And the way things stand currently, the guidelines, I believe, are dialysis patients who do experience hypotension that does not respond to other strategies such as midodrine are currently eligible as a salvage, like second, third line therapy to be on to get some albumin. So that's the current state, and we'll see what happens in the near future. Dr. Churdy has also thanked you for the excellent talk. She says, one point that struck me hard is the moral imperative to reduce use from the perspective of complicity in driving the tragic systemic pathology of plasing, which is underprivileged people incentivized to earn money as repetitive paid plasma donors for the fractionation industry. And we're in a way driving that by using products where they shouldn't be used and creating a need for these products where it's not needed. Any other questions from the group? Any other thoughts from you, Dr. Berchasco?
I think I missed one of Dr. Callum's earlier questions where she wrote, albumin is often used intraoperatively for lower risk of transfusion procedures, and patients get albumin alone, but without a signed blood consent. And then the patient does go home with a letter saying that they were transfused, and then they get upset. So anecdotally, speaking casually with one of the cardiac surgeons a couple months ago, so he actually gave me almost the exact same story where he saw the patient post-operatively right before the patient went home for discharge. Told the patient that they hadn't received any blood products, that we were able to do, the entire cardiac surgery without a single transfusion. The patient goes home, they get a letter that they were transfused. They come back to the surgeon's office for a follow-up visit, absolutely livid because they felt that they had been lied to and they didn't even receive, they hadn't had any knowledge that they received blood products. And as it turns out, somebody had given, 5% albumin or something like that, just like a small dose, like 250 or 500 mils in the ICU post-operatively. So obviously albumin is a blood product. I absolutely agree that people need a signed product consent form for that. And I think this just speaks to maybe a need to change or a general culture around albumin use for people to really start thinking about it a little bit more as a blood product, because certainly patients do after they get that letter.
This is actually quite not an uncommon scenario. So thank you for actually talking to us about it. And thank you for mentioning it, Jeannie. I also have another comment from Dr. Pendergrass. He says a number of RCTs have concluded that we are not using albumin appropriately, and yet there's been little effect on actual practice. What do you think is the explanation for that?
So we actually just finished a survey of about 130 cardiac anesthesiologists regarding their attitudes towards perioperative albumin use. And I think the vast majority of them don't perceive it as being particularly beneficial. However, they also feel it doesn't contribute significantly to patient harm. So a lot of them get into situations where there is ingrained cultural practices. So for example, in the post-operative, more chronic kind of phase of management, really common to use 25% albumin with diuresis to try and get a patient back to their preoperative weight. So people may feel like they're more expeditiously achieving that goal. Whether or not that makes a major difference on patient outcomes is, quite a different question. And more importantly, culture is very different and very difficult to change. So one of the intensivists that responded to our survey actually left us, there was a free text comment box, and he filled up the entire thing, talking about how even when he's personally tried to reduce his albumin prescribing, he'll step away from the patient bedside, and as soon as there's some kind of hypotension or somebody perceives the need for albumin use, somebody else will just come to prescribe it, right? Or sometimes the bedside clinicians taking care of the patient. So for example, the ICU nurses, many of them have been working for 20 plus years. And for them, it's part of resuscitation of a sick patient, right? So I think that there's a lot of outreach that we should do to all of the clinicians in the ICU and perioperative setting, because albumin has historically been very commonly used. And I don't think that that's something that will easily change. It's a practice shift. It's a culture shift.
Thank you, Dr. Bertosco. So I'm not seeing any further questions coming in just yet. I just want to remind everybody that we're always looking for your feedback and your evaluation. The link is now posted. There'll also be a slide with a QR code posted in a moment on the stream here, and we welcome all of your comments. Dr. Cherty actually made the observation that the issue about hypoalbuminemia and the concern around hypoalbuminemia transcends humans, because one of her pugs at their periodic health exam were discovered to have hypoalbuminemia.
That's actually a hilarious comment, because my cat had blood work last year and was also hypoalbuminemic. She's very elderly. So like in human years, she would be like 90, and they also made a big deal about it. So I do think like in the human literature, there's so many observational studies that are being published in the last 5 to 10 years, right? Where in all kinds of chronic health conditions, hypoalbuminemia is associated with poor outcomes for multiple reasons, right? So perioperatively, patients are at risk of, surgical complications, increased wound infections, et cetera. But that doesn't mean that albumin replacement is necessarily the cure for this, right? So.
Fantastic. Okay, so our link is now in the chat. We'll switch to the screen. Thank you again, Dr. Bartosco, for joining us. Want to remind everybody that we'll be back next month, October 28th, 2021. We have a talk by one of my colleagues, Dr. Wasim Anani, on machine learning and transfusion medicine, queued up for you next. And please do share your comments. If you have further questions, Dr. Bartosco provided her email as well. So if you wanted to contact us with further questions, we'll be happy to help you get some answers.